The title of the presentation is the role of laparoscopic surgery in urology, which is a minimally invasive technique that performs through a small incision. Rather than having the surgical site completely open, the surgeon inserts a laparoscope through one of the incisions to view the interior of the abdomen or the pelvis. The procedure typically offers numerous benefits along with many problems. Overall, it is currently a thriving option, particularly in resource-limited settings. So the technique has started with H.C. Jacobius and Kelling's introduction in early 20th centuries, with the development of the cold light sources in the 1960s, further advancing the area. In urology, the first laparoscopic nephrectomy is performed by Kleeman in 1991. More recently, we've seen development of the integration of AI and almost fully autonomous robots, like the smart tissue autonomous robots that operates without human assistance. This all indicates a dynamic evolution and expansion of the role of LS in urology, continually pushing the boundaries and positions and autonomy. More recently, the use of LS in urology is increasing. Look at the image on the right here. We can see that the application rate of laparoscopic surgery was consistently higher than that of open surgery since 2012, while the use of robots demonstrated clear growth tendency from almost 0 to around 20%. Given the esoteric nature of the subject matter, the statistics available are often sparse. One of the few systematic surveys is from Brazil, showing that 75% of the urologists has performed LS at least once. This underscores the increasing reliance and trust in this technology within the urological field and promising growth in robot assisted techniques, and signifies an evolving paradigm. And these all are due to the various benefits of laparoscopic surgery. So the benefits include shorter hospital stays, lower intraoperative blood loss, and as well as post-operative complications. For a specific case, according to the latest international guidelines, the open partial nephrectomy, partial nephrectomy is considered the standard treatment of T1 renal tumors. Laparoscopic partial nephrectomy, which was the first reported by Winfield in 1993, has later shown significant advantage over the open PM, offers lower vulnerability and lesser post-operative pain and earlier hospital discharge. Yet, LS do come with limitations. These typically include longer operative time. It's generally 50% longer than the open counterpart, and it is both mentally and physically challenging to the operating surgeon due to the stress and the complexity of the procedure and the time frame restriction. Plus the need to avoid ischemic renal injury while ensuring a good hemostasis. So regarding the application of it, for kidney-related issues, techniques like a nephrectomy, partial nephrectomy, and piloplasty has become increasingly common with LS. It is also widely applied under in ureter-related procedures like the ureterolithotomy, all of which will be discussed in the next few slides. So in terms of the kidney-related conditions, LS has becoming increasingly reliable. Taking piloplasty, for example, up until 2010, open piloplasty was a standard procedure for uretero-pelvic junction obstruction repair, with a success rate above 90%, whereas LS typically falls short by around 10 to 30%. However, the advancement of LS in piloplasty witnessed a big shift and became the first minimally invasive option that could really match with the open piloplasty. While the success rate is clearly growing from 92% among 62 cases, and later becomes high as 98%. This again reflects the role of LS in urology has becoming progressively solidifying, with its reliability and success rate in procedures like paloplasty having an upward trajectory over the years, and not only catching up but surpassing the outcomes of traditional open surgeries. Well, despite a high success rate in paloplasty, when we consider its performance at a larger scope, there are still unsolved issues. Some concerns are complication rate, equipment limitations, and long-term outcomes. For example, the relation between urethral injury during laparoscopic colectomy is still under debate. This graph shows the... Oh, can I zoom it? No. Urethral injury is a really feared complication that has increasing over the past decade. It is infrequent but potentially lethal during colectomy. These are the potential sites that this can happen during the procedure. Over the years, some researchers like Planyapa have attributed this to increased adoption of laparoscopy, as there is indeed a positive correlation. Take an example from this study by Marcelism. Out of a total of 3,300 cases, the urethral injury rate is almost twice as high in laparoscopic surgery, indicating a positive correlation. However, another study by Zafar 2 years later provides a contrasting view. In their data, out of a total of 94,000 cases, the instance rate in open surgery group was higher than that in 0.66 compared to 0.53 in the LS. So with both statistics, both studies, along with many others having more than sufficient statistical power, yet still yielding conflicting results, this shows a microcosm of the broader challenge in defining the role of LS in urology, which is characterized by ongoing debate and variability in the outcomes, which needs careful evaluation and possibly a more case-by-case approach. It is also important to highlight the role that robotic systems are playing in the landscape, like the widely used Da Vinci system, as they have significantly influenced the practice by bringing several additional advantages. Using these systems, the surgeon operates from a console, controlling the robotic arm that mimics surgeon's movement with greater steadiness. They also offer enhanced three-dimensional vision and a wide range of motion. One outstanding benefit is a short learning curve. For example, it takes around 20 cases to become proficient in robot-assisted LS prostatectomy, compared to 80 cases. So these are not percentage; these are cases. 80 cases for the traditional method. In developed countries, these benefits are well recognized. By 2020, it has been estimated that 80% of the radical prostatectomies in the US are performed robotically. However, the picture is different in developing countries, where the higher cost, along with the lack of availability, making the traditional method more viable. As some experts like Bensil pointed out, robotic assistant definitely offers numerous advantages, but the real question is whether they really translate into clinical outcomes. That's something that largely depends on the factors like cost and will eventually determine the role of LS in a larger context. So, as a conclusion, the concept of role is somewhat multifaceted, and assessing the position of a particular procedure within urology depends upon the benchmark being used. If we consider the parameters such as adaptability, success ratio, and rate of complications, it is shown that LS is becoming more important experiencing more large groove than the areas compared to open surgeries. Nevertheless, as demonstrated in the analysis concerning the ureter complications, the more detailed evaluation needs deeper exploration, case by case. This might shift our attention towards specific areas where the implementation might deviate from the general tendency.